My name is Dr. Jeremy Salmon and I'm a research fellow here in the Health and Ageing program here at the Centre, and it's my job to introduce our speakers and the topic. The topic is the contentious one of preventive health, or rather the role that governments, or rather the role that taxpayer funding should play in trying to make us all healthier. I know from my own work this is a really vexed issue. The many claims that are made about the effectiveness of preventive interventions, particularly surrounding lifestyle and obesity, often don't stack up. And this also includes the idea that every dollar that you spend on prevention is an investment because it delivers a lower cost health system. In fact, rather perversely, the more successful you are in keeping people alive to older ages, the higher health costs can end up being due to people consuming more and more healthcare as they get older and as their health inevitably deteriorates. The big if here is if preventative interventions are successful. The difficulties that policymakers face in determining whether a particular venture into preventive health will be successful is one of the issues that will be canvassed tonight, as well as what constitutes success and how we measure it. Our first speaker is my colleague, Helen Andrews. Helen is a policy analyst at the CIS and the editor of Policy magazine. She has a BA in religious studies from Yale University and has a very impressive publication record in the land of her birth on a range of topics. For the CIS, she's published an important report on the National Charities Commission, and in November last year she published this report, An Ounce of Prevention, a Toolkit for Evaluating Preventive Health Measures.
So I'd like to start by telling you about a simple preventive health program that can save literally thousands of lives at no cost to the taxpayer. There is an activity that most Australian families engage in that is associated with an excess death rate of 7%. And of more than 25% for people in their 20s. If the United States had banned this activity in 2000, 4,500 people would still be alive today. The scourge I am talking about is birthdays. And it's absolutely true. The economist Pablo Pina looked at data for 25 million people over 13 years and found that people in general, and young people in particular, are more likely to die on their birthdays. Possibly because on your birthday you're more likely to engage in activities involving some risk, like swimming or skiing. On the basis of this study, I could launch a whole campaign to get the federal government to ban birthdays. Or I could start an NGO to raise awareness of the dangers of birthdays and to pressure private businesses to discourage the celebration of birthdays. Because if you offer birthday packages at your facilities, you are contributing to needless deaths. I could probably get a government grant. If you read the newspapers, you've probably seen articles that use studies like the one I just cited to make an argument for taxing or banning or discouraging something that the author doesn't like. And unlike me, these authors are perfectly serious. It's the new favorite tactic of the same old nanny state activists that we've had with us for at least a century. And it's very clever of them, really. Imagine a politician who is not inclined to be sympathetic to the nanny state agenda. Come to him and say that we need to ban cheeseburgers, or we need to treat ads for candy bars the same way we treat ads for cigarettes, and he's going to write you off as a wowzer. But if you tell him that we can reduce obesity and thereby save on long-term health costs, he's going to listen. And that's the new tactic, to relabel nanny state programs as preventive health, and then to say that preventive health saves money. Now, the tactic isn't entirely new, and contrary to what you might think, it is not something that came into being with socialized medicine. A lot of people seem to believe that it was only when the government started paying for everybody's health care that the state decided they had a right to interfere in the wellness of its citizens. But in fact, the very first temperance activists made exactly the same argument. They would say, we don't care what people who drink alcohol are doing to themselves, but they are imposing social costs through crime and burden on the welfare system because they can't hold down a job. Although if you know anything about the fanatics who were driving the early prohibition movement, their protestations that their problem was not with alcohol in and of itself ring hollow. But although the tactic isn't new, it has become a lot more sophisticated. With the increase in the sheer amount of data collected by governments and the advent of economic modeling, sometimes known as Lego with numbers, nanny state groups are now able to muster an appearance of specificity and accuracy in their estimates of the total cost of the things that they don't like. And the proliferation of degree-granting programs in new disciplines like nutrition science and physical education, which you can get a PhD in now, has given the authors of these claims the benefit of academic credentials. And if you get a graphic designer to present your graphs in a shiny, glossy form, you're ready to launch your campaign. It can be difficult for the average citizen to know where to begin in picking apart these glossy and confident preventive health reports. Something about them sets off your common sense alarm bell. You say to yourself, these guys are saying we can save millions of dollars by giving millions of dollars to people like them? That's pretty convenient. And aren't these the same people who have been professional wowsers for the last 20 years? Doesn't that make their embrace of this new data a little bit convenient as well? But although your common sense smells a rat, it's not always easy to detect where the flaw is. Sometimes there's no way to do it except by diving deep into the data, but often that's not necessary because preventive health activists use the same tricks again and again. And if you learn how to recognize those tricks, you can prevent yourself from being fooled. Some of these tricks involve playing with numbers. If, for example, you want to get a very high number for the amount that obesity costs Australia every year, there are a lot of ways to do that. You can pile absolutely everything into that total, for example, by factoring in lost productivity costs, because obese workers are more likely to call in absent and less likely to be maximally productive at work. There was a study published by the Brookings Institution in 2010 that included in its estimate for the total economic cost of obesity $2.5 billion annually in excess fuel used by non-commercial passenger vehicles, because heavier people are more difficult to move, as well as human capital accumulation costs, by which they meant that obese children are more likely to be absent from school, which interferes with their accumulation of human capital. Of course, these studies are never quite so inventive when it comes to coming up with benefits of alcohol or high-calorie foods or whatever it may be. It has been shown that if you take a group of mice and you put half of them on a diet and you let the other half eat as much as they want, the dieting mice will be more irritable, more agitated, and more likely to bite their handlers. But somehow I have never seen one of these obesity cost studies that factors in diet-induced lost productivity costs due to irritability. And that may sound like a joke, but the issue of irritability and the psychological effects is actually a very real one if you're talking about, for example, a wellness program, a workplace wellness program, which is just a preventive health program on a smaller scale. If you're a manager and somebody comes to you and says, we've got a program that can lower employees' average cholesterol by however much, you need to balance that against a potential loss in morale if your employees resent the fact that their boss is trying to micromanage their private decisions. Another common trick is to take a modest claim or a modest study and then snowball it. A Melbourne-based public health professor recently wrote on the website The Conversation in an article on preventive health best buys that have good return on investment. Reducing children's exposure to junk food advertising would be the cheapest and most effective way to reduce obesity. Now, it's true that if you show preschoolers a junk food ad and then present them with a range of snacks, they're more likely to choose an unhealthy one. But thinking about how you get from that to a return on investment from lower incidence of disease due to reduced obesity, there are a lot of links in that chain. You have to assume that by regulating junk food advertising, kids really will eat less junk food, and that assumes that they're eating junk food because they're brainwashed into it and not because it's delicious. You have to assume that the reduced consumption of junk food is not going to be substituted through increased consumption of other equally dubious foods like peanut butter and cheese. You have to assume that these better eating habits are going to last through childhood and into adulthood when they're responsible for their own budgets, and it's not going to be offset by physical inactivity. That's a long way to travel before you get to reduced incidence of disease and reduced costs. There was a study done at Cornell which found that preschoolers are 4 times more likely to choose a healthy snack if you ask them, what snack would Batman eat? But I've never seen anybody arguing that we should subsidize Batman merchandise on those grounds. And then there's the most important point, which is that although obesity is associated with disease, and disease is associated with costs, obese patients do not cost more over the course of their lifetimes than healthy patients. In fact, they cost a little less. Now, public health activists don't like it when you point this out, and they accuse you of wanting people to die sooner. Simon Chapman, who's kind of the king of Australian preventive health nannies, has written, "This homo economicus view of health is little different to that used by Nazi camp guards in pulling inmates out of work duty for execution when their camp productivity fell due to illness." That's Simon Chapman. But if anti-obesity and anti-alcohol and anti-smoking activists are going to stake their argument on the claim that preventive health saves money, then they can't complain when people argue with them on the ground that they chose. It is true that healthy patients cost more over the course of their lives because they live longer. But there are other facets to the question that complicate this simplistic view that obesity equals disease and disease equals cost. Something you may not know, in 1987, an obese patient's average annual healthcare costs were 8% higher than an average healthy patient's. Not over the lifetime, but annual. In 2008, that had ballooned to 38%. So the gap between obese costs and healthy patient costs had increased. So it's true that obese patients are costing us more now, but some of that is simply because we've come up with more treatments and more expensive treatments for their particular ailments. But setting all that to one side, none of what, there's a sense in which none of that really matters. None of however long I've been speaking. Because even if all of these estimates for the cost of obesity and alcohol were completely accurate, the looming question is still, what are you going to do about it? No country for which we have data has succeeded in reducing obesity, and nothing that the preventive health lobby has proposed seems likely to change that. Nobody did more than Mayor Michael Bloomberg to experiment with new innovative preventive health programs, and obesity rates in New York City still rose from 1 in 5 to 1 in 4 over the course of his tenure. A lot of the so-called success stories that the preventive health lobby likes to trumpet turn out to be a lot less successful when you look at them closely. The Australian National Preventive Health Agency, the late lamented Australian National Preventive Health Agency, boasted in its big promotional brochure in 2013 about the Get Healthy coaching and information service, which was a pilot program they'd done in New South Wales. And they claimed that the Get Healthy program had led its participants to lose weight and keep it off. Now that's true, but the Get Healthy program had involved people who signed up for it because they had already decided that they wanted to lose weight, and the average weight loss across the whole program for people who completed it was 4 kilos. If you're going to address the so-called obesity epidemic, you're going to need to reach people who have not committed to losing weight, and you're going to need them to lose more than 4 kilos. The Clinton Foundation in the US funded a pilot program with insurance companies where it got the insurers to cover anti-obesity programs for children with high BMIs. And the insurers agreed to cover, I think, 4 visits to a dietitian and 4 visits to a pediatrician for any child whose BMI made them eligible. The pool of children covered was 2.5 million. The pool of eligible children was in the hundreds of thousands. But the insurers had to go to the Clinton Foundation and say that they had each managed to sign up only 50 kids. And they had no data on whether the 50 kids actually lost weight as a result of the program that they participated in, or indeed whether the kids who did lose weight would have lost that anyway. Getting school children to eat more fruits and vegetables. That's a perennial target that preventive health programs set. Most of these programs show no increased consumption of vegetables, and the ones that do, often the effect fades within 2 years. And even the ones that do get them to eat their vegetables, very often the kids don't lose weight because they're eating more vegetables. There was a pilot program in Mississippi where they literally gave away vegetables at school. Consumption of vegetables did not increase. Although the students did report, quote, more positive attitudes towards eating fruit and vegetables. The researchers concluded distributing free fruit and vegetables at school may be a viable component of a more comprehensive approach. Translation, this isn't working, but we're not giving up on the narrative. For what it's worth, in Australia, obese and overweight adults are actually more likely to be eating their recommended daily servings of fruits and vegetables than people of normal weight. So the money spent on the Go for 2 and 5 campaign to get people to eat their 2 fruits and 5 vegetables may not be providing value for money. But setting aside these pilot programs, what about taxes? That's the newest thing in nanny state campaigning. A lot of these proposed sin taxes fail before they even begin because they can't decide precisely what to tax. It sounds like a good idea to have a soda tax or a junk food tax, but what should be included? If you tax soda, what about fruit juices that are just as high in sugar and calories? If a donut is junk food, what about a scone that has just as many calories? But even assuming you can sort all that out and you design a junk food tax and you implement it, it's unlikely that you're going to make any money in reduced health costs, although you will get money from the tax. British economists decided to model a 100% junk food tax because they figured this was the absolute limit of anything anybody might conceivably imagine. All candy bars and all soda now cost twice as much. And they estimated that it would achieve an average reduction in BMI of only 0.2, which is not really a lot of bang for your buck. And that's the absolute limit scenario. Denmark is the country that has done the largest real-world experiment with a fat tax, and they scrapped it just about as soon as they implemented it because enforcement costs were too high, people were substituting, people were running over the border. It didn't work. A more realistic scenario might be something like a small soda tax. But even something like that is unlikely to work because of a simple reason. Lowering soda consumption overall is not going to reduce obesity-related healthcare costs because you don't really care about total consumption of soda. You only care about the consumption of soda on the part of the people who are going to be causing obesity-related healthcare costs down the line. So that's the very tail end of the curve, the hardcore soda drinkers. And they're the people who are least likely to respond to a tax. So it's been a lot of figures. I will end with a statistic that's probably my favorite. People in general get heavier as they get older. In fact, the average person gains 1.5 kilos every 4 years of their life. But for people who eat French fries, the average is 3 kilos. That's twice as much. Now, does that mean that if we banned French fries, we could get those people to gain weight at half the speed? No. Because person who eats French fries is really just a stand-in for person who places a high priority on taste and a very low priority on maintaining their figure. If it's not French fries, it would be something else, because those people's priorities will still be the same. It's all down to personal behavior. If a person is not willing to change their personal behavior, the government can't force them to. And the little tweaks that are within the government's power to change aren't enough to make up for the fact that someone has decided they're okay with being obese. The preventive health lobby seems to think that it would help to harass these folks a bit, to make being obese a little more annoying or a little more costly, to motivate them to lose weight. But keep in mind that being obese is already pretty darn annoying in the first place. We talk about the social costs and the healthcare costs of obesity, but the individual personal costs are already quite high. You have lower self-esteem, you have aches and pains, you have shortness of breath. I'll close with a quotation from Dr. Ben Goldacre, who's a British physician who's also become a popular science writer. He runs an entire blog called Bad Science, where he calls out errors and evasions in published articles in science journals and medical journals. And this is from a letter that he wrote to the BMJ criticizing an article hyping a preventive health program for heart disease. He said, "When we offer any preventive treatment, we are acting less like doctors and more like a life insurance sales team. We are offering occasional benefits many years from now in exchange for small ongoing costs. Patients differ in what they want to pay now in side effects or inconvenience, and in how much they care about abstract future benefits. Crucially, the benefits and disadvantages are so closely balanced that these individual differences really matter." It's true. There is a fundamental difference between responding to a person who is sick and come for you for help, and pursuing a person who right now is perfectly healthy, but upon whom you want to impose a treatment. All medical treatments involve some risk, and all government programs involve some cost. So the threshold for how confident you need to be about the effectiveness of your treatment is much higher if you want to target people who are currently healthy or a problem that does not yet exist. And for the people who are labeling their political activism with the name preventive health, that is a higher standard that they often fail to meet.